All right, so hi everybody and welcome to today's session, The Devil is in the Details, Race-Based Medicine in Genetic Counseling. My name is Elizabeth Feig and I want to thank you all for joining. Before we get started today, I wanted to cover a few announcements and recommendations for you. NSGC is committed to providing a safe, productive, welcoming, and inclusive environment for all meeting participants and NSGC staff. As a reminder, a link to the attendee meeting code of conduct has been included in the chat at the start of this session for your reference. In regards to session logistics, please make sure to mute yourself if you're not personally speaking. As a reminder, this session is being recorded and will be available on demand following this live presentation. Throughout the session, we encourage you to submit questions through the chat function of the Pathable platform. Our speakers will be working to answer questions and interact with attendees throughout the session. We will also be doing a hallway chat later today at 5:35 to 6 p.m. Central Time. As a reminder, for those claiming CEUs, you'll be asked to provide an attendance verification code for each session. The attendance verification code for this session is 4817, and it is also in the chat. And now it's my pleasure to introduce our speakers, whose full bios are all available in our Pathable profiles. Sally Rodriguez.
Sorry, if we can switch the displays, we can see the presenter view. Good morning, everyone.
My apologies.
Thank you for putting that in the chat.
All right, how about now?
Perfect.
Excellent, thank you very much. All right, so back to our speaker bios. So Sally Rodriguez is a licensed and board certified genetic counselor who specializes in the area of reproductive genetics and currently serves as a genetic counselor at Sequence 46, a PGT laboratory. Carla McGruder is a senior clinical genetic counselor at Color Health, where she provides leadership on the All of Us research program. My name is Elizabeth Feig, and I'm a senior genetic counselor in the adult genetics, endocrine, and pharmacogenomics clinics at Brigham and Women's Hospital, as well as a site coordinator for the Brigham Harvard clinical site of the Undiagnosed Diseases Network. And we have no conflicts of interest to disclose. We wanted to start off with a poll, just asking about how attendees in this session assess a patient's race, ethnicity, or ancestry. So the options are A, via an intake form or self-reported data, B, asking verbally during the appointment or self-reported data, C, outside referral notes or medical record, D, physical appearance, so clinician inferred, or E, I do not ask for or document race, ethnicity, or ancestry for patients. So I'll give you a moment to provide your answer here. Looks like most people are leaning towards B. Definitely majority B. So fun. Just good to know.
Elizabeth, I think you need to switch to the responses view.
Very much.
We can't see anything.
Mm-hmm. Well, I'm not sure how to get that to show up, but I can tell you that the vast majority of people are saying B, 80% are saying B, 13% are saying A, and 6% are saying E. And numbers for C and D are not statistically significant / showing up at all. So quick little profile there. Now we'll pass it over to Carla to talk more about background on this session.
Thank you so much, and good morning, everyone. I can also see in those of you who are in Pathable that there are A, B, and also E showing up a lot, and really wanted to talk about that because certainly in 2020, we've really been grappling with race. At last year's NSGC, we all sat here, sometimes uncomfortable, as people put in the chat, on Twitter, Instagram, everywhere, there are different views on how coming to terms with what racism is in this country affects us, not just personally, but how it bleeds over into the professional space. And NSGC did a great job of first coming out with a statement that was a few sentences long, talking about JEDI efforts. That statement then went on to go into gathering up all of the different views that we saw in the chat, all the different resources we had. Next slide, Elizabeth. To show all the different things that we can do to be better when it came to race. And then finally, which I highly encourage everyone to look at, the Exeter report came out and it was already underway, but really got all into our business, everything that we've been doing as a society to figure out how we can be more diverse. And so really quickly with medical racism, talking about all the different isms, there's certainly racism in banking and criminal justice, but certainly in healthcare, we can see it manifest in different ways. It can be on the individual level because healthcare providers still are people. And so if someone has some racist views themselves, and then they train their residents, fellows, students that same way, racism shows up that way. Also collectively, if we decide as a group that racial discrimination, say this group, we say maybe eats a certain way and that's why they're unhealthy, then that's a way for us to justify why maybe they have different medical treatment. And certainly negative impacts on health and overall the quality and quantity of healthcare are all ways that we can define medical racism. And the impact of that is more than just, oh, you hurt my feelings, or oh, your microaggressions. No, want to be very, very clear that medical racism and racism in general is an act. And it leads to primarily in Black people, higher blood pressure, lower flu vaccination, and an overall lower life expectancy that has been documented over and over. And I'm not going to go too much into these concepts because luckily we have a great plenary on Saturday that's going to go into that. But it's beyond just talking about Tuskegee and Henrietta Lacks. So many times we say, well, maybe people don't trust medicine or the medical racism happened in the generation before. No. Currently, there are still things that are happening where people who are in pain, especially those of the sickle cell patients in crises, can't get pain medication because they're not believed due to race. Also, even putting in race in the history of present illness when you're presenting at case conferences has been shown from the very moment you mention someone's race to impact what the medical decisions are for those people. And there are certainly pivots in other parts of medicine where, for instance, with the National Kidney Association, they are not using the EGFR scores for kidney transplants that show different scores for African Americans. There's other ways that we're changing. But beyond Tuskegee and Lacks, there's also racism in genetic counseling. Yes, we can be gatekeepers for sure. There's been documentation that women who are lower socioeconomic status or minorities have to show a higher burden of proof when deciding if they should have testing. So say the woman who says that her aunt has an ovarian cancer, looking at race is when you choose to say, maybe you should go home and see if that's really the case, and then we'll have testing, versus believing people who are European. And there's implicit bias in other areas as well. So overall, race-based medicine is still a problem and it's overlooked, but we're hoping to delve into that more today. And so we've already defined medical racism and just summarizing some impact, but we hope to discuss race and how it's been used in the wrong way and how that differs from ethnicity and ancestry, going more into detail into the prenatal space, cancer space, and pharmacogenomics. And then luckily, of course, as genetic counselors actually give you some opportunities and some solutions on how to be more impactful in combating this in an active way.
And so we wanted to start off by talking more about what we mean when we use the terms race, ethnicity, and ancestry, or REA. And there's no single definition for these three terms and their precise meaning. So that makes it important that we be clear with how we're using these labels to refer to data. In general, race and ethnicity refer to social and not biological categories. So race is a label that refers to the color of one's skin and is a social construct. And this term might be used to describe health disparities in societies that are characterized by racial categories. Ethnicity refers to culture and may be used to describe traditions, lifestyle, diet, and values. And ancestry can be a biological trait based on genetic variants that result from reproductive isolation and population drift. Genetic data from genome-wide association studies, or GWAS, can be used as an objective and biological way to trace and measure genetic ancestry, though it's important to note that this data might not always align with somebody's self-reported ancestry. A very important concept in genetics when we're talking about ancestry is admixture. So admixture describes our ability to reach new geological populations and reproduce to create offspring with mixed ancestral lineage. So essentially a term to categorize the fact that many people have genetic ancestry that represents more than one population or geographical group. And I'll pass it over to Sally to talk more about race-based medicine and how this plays a role in the prenatal space.
All right. So good morning, everybody. I think most of us would agree that carrier screening is complex, or it's certainly become complex in more recent years. There are a lot of factors to consider, from how best to provide pre and post-test genetic counseling, to how to manage residual risk calculations, to all the logistical considerations, like helping patients determine their insurance coverage and their potential out-of-pocket costs. But I only have a few minutes today, so we won't be covering all of that in detail. Instead, I want to focus on the pitfalls of race or ethnicity-based carrier screening and the ample evidence that we have for moving towards a pan-ethnic approach. So historically, and if we're being honest with ourselves, this still applies today. A majority of genetic disease research and developments have focused on diseases that have higher incidences in white populations. For example, the first major carrier screening effort in the United States was for Tay-Sachs disease in the Ashkenazi Jewish population, and this started in the early 1970s. Another more common example would be cystic fibrosis, which has had a lot of dedicated research due to its incidence, particularly in white populations, its severity, and its limited treatment options, though fortunately that's changed significantly in recent years. The gene was discovered in 1989, but it took until the early 2000s before ACOG and ACMG recommended screening. And even then, there were caveats based on race, since screening at the time was just for a limited panel of about 25 mutations. It took 10 years before both organizations updated their guidelines to indicate everybody should be offered testing equitably, but that limited mutation panel recommendation still stood. I'm sure you're all familiar with this chart that depicts the CF detection rates across different racial or ethnic groups for that limited mutation panel. Bottom line, if you had two patients of different races who had the same insurance plan, paying the same premiums, they would ultimately get different levels of care. Of course, as we all know, by 2010, there was a big shift in the field. We completed the Human Genome Project in the early 2000s. There were various technological advancements, and that led to a significant decrease in the cost of genetic testing. This allowed for the analysis of more mutations and diseases via a single platform, which made carrier screening more cost-effective. And this led to the genotyping-based carrier screening panels that we saw launch around 2010, followed by the sequencing-based panels that are commonplace today. As the landscape continued to evolve, updated society guidelines slowly began to emerge. In 2015, several societies, including NSGC, published a joint statement indicating that expanded carrier screening was an acceptable approach and addressed various important aspects. From an implementation standpoint, they emphasized that a key premise of this approach is that all patients, regardless of their self-reported race or ethnicity, should be offered the exact same testing panel. But 2 years later, ACOG issued an individual committee opinion stating that all three potential approaches, even a race or ethnicity specific offering, were acceptable strategies. So what exactly is the problem with self-reported race or ethnicity? Well, as Elizabeth mentioned earlier, race and ethnicity are both social constructs, and they're not necessarily reliable indicators of genetic ancestry. I hope the images here will help you visualize this point. In 2017, a carrier screening lab that I was working at the time published a study where we compared self-reported race or ethnicity to genetic ancestry. We developed a model that used approximately 600 SNPs that show high variability in allele frequencies between populations, and validated that model on samples with known ancestry from the 1,000 Genomes Project. This first plot shows the results for the samples from the 1,000 Genomes Project. And in this plot, each thin vertical line represents an individual sample, and the colors represent different genetic ancestries. So for example, for the first 500 samples on the left side of the plot, those are for individuals with known African ancestry. And as expected, each line is majority red, which in these images is associated with African ancestry. The next set of 500 samples are from individuals with known East or Southeast Asian ancestry. Sure enough, every line is majority light blue, which is associated with East Asian ancestry, and some have a bit of green, which is associated with South Asian ancestry. Now, the plot on the right shows the samples from patients who had carrier screening performed by the laboratory, specifically those who had Latin American ancestry indicated on the test requisition form. As you can see, this is a group with significant genetic admixture. Some patients had clear majority European genetic ancestry, as represented by the dark blue, while others have majority African ancestry, shown in red, or indigenous or native ancestry, shown in yellow. So the carrier screening, or excuse me, the carrier risks for individuals marking the same ethnicity, in this case, Latinx or Hispanic, could be quite different. And if genetic testing recommendations, which can have significant downstream effects, are going to be made based on a patient's reported race or ethnicity, it's a real problem if it's not a reliable measure. The other piece to consider is that ethnic and racial admixture has steadily increased over the last decades. A 2015 analysis of 2010 US Census data found that 17% of newlyweds, or about 1 in 6 people, were married to an individual of a different race or ethnicity. For comparison, in 1967, the year in which the Supreme Court made interracial marriage legal across the United States, which was not that long ago, this rate was just 3%. When we look at recently released 2020 census data, we see a significant increase in the percentage of people who identify as multiracial. In 2010, that was about 9 million people, and in 2020, it was over 33 million people. Part of the increase is likely due to improvements in the census questioning strategies, but regardless, this is a trend that will undoubtedly continue. These trends have and will continue to have an effect on carrier screening frequencies of different conditions across populations, making race and ethnicity-based testing recommendations difficult to maintain or justify. When we spend less resources on certain genetic diseases or certain populations, there's a downstream effect, and health disparities will inevitably arise. In the carrier screening space, this results in things like unknown carrier frequencies and uncertain detection rates in understudied populations, missed carrier status or carrier couples, and thus missed opportunities for preconception or prenatal decision-making. And these kinds of disparities continue to trickle downstream. If we take cystic fibrosis as an example, we get a clear picture of what this looks like. Non-white infants with CF are more likely to carry mutations that aren't included on newborn screening. And so they are more likely to be older at the time of diagnosis and more likely to have significant health issues like failure to thrive. Per the CF Foundation, in 29 studies conducted over a period of 15 years, Black and Hispanic people with CF only made up about 3% of study participants, despite the fact that they make up about 7% of people with CF. And as you can imagine, this continues to trickle down. Because people of color are more likely to carry mutations that are less common and less likely to be included in research, they are in turn less likely to have access to the newest medications that have resulted from said studies. And some of these medications are now considered to be life-saving or life-extending. And so when you look at the bottom line outcomes, the data is a bit bleak. Black and Hispanic individuals with CF have a 2-fold higher risk of dying before the age of 18. Fortunately, there's at least a little bit of good news to help us start to close these gaps. Just a couple of months ago, ACMG issued an updated practice guideline on carrier screening that replaces their 2013 statement. There's a lot covered in this publication. I know there's been some controversy regarding certain aspects of their recommendation. For the purposes of today, I want to keep the focus on the race and ethnicity aspects. And as you'll see in the quote that I've highlighted from the publication, ACMG is acknowledging what I hope we're making clear so far, that using race and ethnicity to determine who gets screened for what is both inequitable and scientifically flawed. This is a great first step, but the work doesn't stop here. We'll share more later on what we can do as a profession to help continue this trend. But right now, let's take a step away from the prenatal realm and switch gears to cancer.
Thank you so much. And the chat is on fire, guys. I'm so excited to get to the Q&A portion and for you to listen to more, especially at the end of this talk on the solutions that we offer, but also want to plug that we do have a hallway chat later on this evening. If we don't get to your question, we can hang out in a Zoom later on. So look for that on your calendar. And so I want to talk a bit about polygenic risk scores, which was something that was also discussed all over 2020. We've been talking about risk models in breast cancer for quite some time, longer than some genetic counselors have even been alive. And I love that because it helps us acknowledge that we don't have all the genetic information, right, to point to what's happening, but we can then use risk models to acknowledge people's very real experiences of what they're seeing in their families to know that you do have a higher risk and we can calculate that. It was really in 2017 when the PRS, polygenic risk scores, really came into fruition. And to give just a little bit more background on polygenic risk scores, this is something that compares the genomes of people with disease and without, so it uses relative risk. And based on all these different genetic variants, it calculates a risk score, right? It puts you at high risk, low risk, and then we go from there. I also want to point out and think that it's very, very imperative to note that polygenic risk scores are still considered research. We use them as something that's clinical just because they're actually put on reports. And we know that once they're put on reports, no matter what kind of caveats that we mention, people are going to actually use them for clinical decisions, right? And so the Human Genome Project came out and showed that, oh, we have all this information. We know exactly who people are. Wrong. We know exactly who white males are because that's exactly who took part in most of these studies. 78% of people who are in there are European. So the Human Genome Project is more of a rough draft of the human genome than actually representing all of us. And certainly when it comes to PRS, we screened and we granted and continue to do so because it leads to more inequality in breast cancer care. And certainly breast cancer care, there's been disparities in other places besides PRS. So if you ask any Black woman or really any other person around who looks at who's actually passing away from breast cancer, you will hear this misnomer or this misconception that Black women actually have a higher incidence of breast cancer, but that's far from true. However, we die more from breast cancer. And so it's really important for Black women and for all women, all men as well, to get actually increased breast screening when we know that there's a problem to add to tackling these things before there's a high mortality rate. And so if you have a documented increased risk of breast cancer, that leads to so much access to things like insurance coverage, changes in how a person sees their risk. They can say, you know what, I do have a high risk for cancer. Maybe I should not put off that mammogram I've been putting off for the last 3 years, and also increase health literacy. Since they're now in this space of high risk, they know what an MRI is, they know what other terms are, we're really including them in the space. So when you take that away and they actually don't have access to higher risk, you don't get any of that access. Maybe they say I can go ahead and go to Disney World this year and put off that mammogram once again. And as a result, it leads to still having a higher rate of disparities. And I always want to include, and maybe I'm including this because I'm completely out of DoorDash money, and so money is a real thing for me right now. But when we're looking at these reports, having a report that doesn't have that information still means that people pay for that. There is no decrease in cost. So we don't get to say, well, you're getting a less useful test report, so let me discount that for you. Still being charged the same amount for unequal care. And certainly there are people who play the devil's advocate and they say, you know, this applies to most people. You know, yes, we need to do better. We'll come around to that. But why are we putting out something that can help the majority of people when we're just looking at a minority of people? But we have to hold the phone on that because Europeans are not the global majority. If we're actually looking at who's the global majority, that belongs to people in Eastern Asia and also in Southern Asia. They kind of rival each other between 1.4 billion for China's population and India's population. So we're not even talking about the global majority of people here. So that's not something that's true. Also something that can be said, and I get it because it's a lot of work. Okay, if you don't have people who are participating in the research, then we need to make sure that they participate in research to help themselves. But want to make sure that you know that African Americans, Black people, Puerto Ricans, Latinx people, people who don't have money all over the world have been participating in research just involuntarily for years and decades, where now there is issues of the medical system not being trustworthy enough. The onus is really on us to make sure that our study designs and things that we put out there are inviting to everyone to participate in research. And there have been updates in commercial testing. All the ranting, all the tweets, all the hashtags last year led to one particular lab saying, we're going to actually stop for a second and review what we're doing and not offer this. And most recently, there was a lab that actually said, okay, we've had this out for some time, and now we've included it to expand to other women. And while that is something that is promising, again, it's still something that's researched. We still need more data. I know there was a talk this morning. I'm sorry I didn't go to that, but I know from looking at the white paper, still seems to be broad groups where it seems like we all fall in 3 groups for some reason and not all the other groups. And also something to point out is now that we have this information, what are we going to do about those people who historically have not had access to the testing result? Is that something where we're going to say, great, now we have this data, we're going to apply it to other people? So happy that we're having these conversations and so happy that laboratories are taking that stance to make sure that we do better, but it's really acknowledging the damage that's been done and figuring out if we're going to offer products, and even with the renewed product that is supposed to apply to everyone, understanding that it still performs way better when you look at the p-values with those who are Northern European. And we want to be sure that we know about PRS because it's not going away, and it shouldn't. This is something that should be really promising because we're still figuring out more things with genes. And so it'd be great to have risk scores. And it's going to be in other spaces, and certainly in the prenatal space, it's already booming. So we want to make sure that we answer these questions about PRS scores, what they mean, what they don't mean, who they apply to as it starts to expand across other areas in medicine.
Right, so I'm going to talk about race-based medicine and pharmacogenomics. Give very brief background. If you are interested in more, there's an SGC course on pharmacogenomics that I would recommend. But essentially the goal of pharmacogenomics is to utilize genetic information to help us predict and understand how genetic variation impacts drug metabolism and response. And the goal is, or the hope is, that this increases safety because we can reduce or avoid an adverse drug event from happening, as well as increase efficacy because finding the best medication and dosage for a patient helps reduce that trial and error process and cut down the therapeutic odyssey. Medication response is highly variable between patients. And this is due to a lot of different factors, such as diet, existing health problems, medications that someone is taking, and med-med interactions, as well as genetics, which accounts for about 15 to 30% of the variability in response between patients. And understanding the factors that influence drug response is useful because it can provide information that allows for more tailored treatment decisions to, again, hopefully maximize a positive drug reaction that will control someone's symptoms and minimize an adverse drug reaction, or ADR. ADRs are extremely common, and about half of them occur when a patient is on the standard recommended starting dose of a given medication. We need to be using all possible tools available to avoid or reduce ADRs because they're a significant cause of patient morbidity, mortality, and cost to the healthcare system. There's limited guidance from professional organizations regarding what, if any, pharmacogenomic testing should be ordered for patients. And that really leaves providers with the burden and responsibility of figuring out how, what, and when to order testing for a patient. There are a few different options on what to order. Testing could be a broad panel of genes or more focused to a specific indication or gene. And panel testing generally has broader utility and higher yield of actionable results that might be relevant over a patient's lifetime. But bigger isn't always better with pharmacogenomic panels, since large panels will typically include genes that don't have evidence-based guidelines to support clinical application of results. A provider might also use the race, ethnicity, or ancestry of a patient as a factor in ordering pharmacogenomic testing, on the assumption that this is a cost-effective approach. While allele frequencies do vary across different ancestry population groups, testing, quote, higher risk patient populations isn't an effective screening method if we aren't accurately and correctly defining and identifying those high-risk groups. So not only is race sometimes used to determine what testing to order for which patients, it can also be a factor involved in how results are interpreted. One example of this is in the setting of warfarin, which is a significant medication in pharmacogenomics because there are multiple genes with clinical guidelines related to warfarin prescribing. Warfarin, or Coumadin, is a commonly prescribed blood thinner and a very common cause of adverse drug events, partly because of the challenges in calculating dosage, which is based on clotting values that can change regularly for patients day to day. This makes it especially helpful to have any information that could help guide dosage, such as pharmacogenomic data. And there are many genes that are associated with warfarin response, one of which is the CYP2C cluster. There's a single nucleotide polymorphism, or SNP, in the CYP2C cluster that was identified in 2013 through a study looking at warfarin response in different population groups, which were measured and defined using GWAS data. This SNP has a high allele frequency in multiple population groups, but a meaningful association with warfarin response was only seen in patients with African ancestry. And because of this, the interpretation of the CYP2C cluster SNP depends on a patient's ancestry. If the SNP is present in patients of African descent, it is considered clinically actionable for warfarin dosing, and the recommendation is to decrease warfarin dose 10 to 25% in that patient. If the SNP is present in patients of non-African descent, it is not considered clinically actionable for warfarin dosing, and there are no changes recommended. There are no guidelines for interpretation or application of the SNP when there is admixture or no available data regarding a patient's ancestry. There are a few issues here. It's concerning that we're using an indirect genetic marker to predict drug response, given that we don't understand the primary mechanism of this SNP and whatever other variants are co-segregating. Additionally, it's unclear how clinicians are supposed to determine whether their patient is of African descent, since GWAS data is not typically available to confirm ancestry for patients in clinic. Is there a cutoff for how African someone needs to be for this SNP to matter? What would you do for a patient who's half African and half European? There's no guidance provided for how to account for admixture, which is a big problem. The next example is looking at how race is factored into HLA genetic screening guidelines for specific medications, carbamazepine and abacavir. There are certain HLA genotypes that are associated with an increased risk of severe and potentially fatal adverse responses to these medications. The HLA genotypes have different allele frequencies across population groups, which can be used to guide screening recommendations. For the first example here, the FDA recommends genetic screening for the HLA-B 1502 allele prior to initiating treatment with carbamazepine in patients who are, quote, high risk, which is defined as being of Asian ancestry. This is despite the fact that the HLA-B 1502 variant is also present in non-Asian population groups and is notably absent in some parts of Asia, such as Japan and South Korea. Conversely, the FDA recommends testing all patients for the HLA-B 5701 genotype, the second example here, prior to initiating treatment with abacavir, given the increased risk for a severe immune reaction. This recommendation for broad pan-ethnic screening is despite the fact that, like the first HLA example, the HLA-B 5701 genotype is also more common in some population groups than others. These are both extremely severe and life-threatening ADRs. So why does one gene-drug pair have pan-ethnic screening recommendations while the other does not? The reasoning behind race-based pharmacogenomic testing approaches is that testing high-risk groups is a more cost-effective strategy. But people can't be easily sorted into cleanly defined REA categories, especially when we're using patient-reported or provider-assigned data. And the pharmacogenomic clinical guideline for carbamazepine even highlighted the limitations of self-reported REA data by citing a study in which 4 of 12 individuals who were initially thought to be of European ancestry were found to carry the HLA-B 1502 allele and subsequently determined to have Southeast Asian ancestry. When we use race to identify patients who warrant genetic screening, we are going to miss patients, and that compromises patient safety. We should be using a pan-ethnic population screening approach for all pharmacogenomic genotypes associated with high impact and high risk adverse drug responses across population groups. And now I'm going to pass it over to Sally, who will talk more about action items and what individual genetic counselors can do.
So we just told you about a lot of problems. So what can we actually do to help solve these issues? First, genetic counselors play key roles across genomic medicine, from developing and ordering genetic tests to variant curation and research study involvement to facilitating patient decision-making and educating other healthcare providers. This means that there are many opportunities for all of us to change the processes that are perpetuating racism and healthcare disparities. So what does this look like in terms of specific actions? Well, in the prenatal space, first of all, we should be offering the same carrier screening panel to all patients, regardless of race or ethnicity. And we also need other reproductive or genetics-focused societies to issue updated guidelines. For example, ACOG. At the end of the day, OBGYNs are the ones who order the most carrier screening. This can help move the field forward and hopefully can help speed up the sometimes painfully slow payer policy process. Once we see changes in payer policies, this will mean reduced out-of-pocket costs for patients, which in turn increases access and equity for all. In the cancer field, we should be challenging the status quo. Utilization of inequitable PRS offerings means that we're being complacent and maybe even complicit, and that's not okay. In the pharmacogenomics space, we should move to offering patients a broad assay regardless of race, which will in turn improve patient access to treatments. Across all specialties, we need to do what we can to increase diversity in genomic databases and research studies. This will ultimately help the scientific community gather the data that we need to close gaps in healthcare disparities. Now, one final thing that we'd like to make clear is that race is not a dirty word. It's okay, and in fact, it's often necessary to collect race and ethnicity data from our patients in clinical care and in research. Racism in medicine can lead to disparities in outcomes, and so we can use this data to study those differences and understand where institutional racism continues to have effects. But what we cannot do is use race and ethnicity data to study biological differences. Both are social constructs, and they're not reliable indicators of genetic ancestry. Because race and ethnicity are complex, it's important that we collect this data thoughtfully. This means allowing patients to self-identify rather than using any clinician-inferred categorization. We should also be using the correct terms and categories, which should be standardized across the field. And lastly, we should be allowing individuals to select multiple racial and ethnic categories. As we saw from that recent census data, the number of folks who identify as multiracial is increasing, and we want to be sure that we're comprehensive in this kind of data collection. So with that, we'd like to thank you for your time today, and we'd like to thank NSGC for inviting us to present. We have a few minutes left. We'd be happy to answer some questions we saw come through on the chat, or you're welcome to contact us by email or find us on Twitter.
And there are also, again, the hallway chat where if you refresh your schedule, you'll be able to see that. We'll have a little bit more time, me, Elizabeth, and Sally to answer questions. You have been, again, lighting up the chat and Pathable, so I absolutely love that. One of the things that's been brought up a lot of times is, okay, well then what do we do about race and how do we ask that question? And insurers and people ask this. We are the experts with this. We are the experts with ancestry, with genetics, with how that entails who we are. Yes, we want to make sure that people get their testing covered. So those are some questions we have to ask. But perhaps, as our last couple slides stated, with our solution, we need to be the canaries in the coal mine to say, hey, these questions that we're asking don't make sense in 2021. It's been brought up a couple of times that not everyone knows their ancestry enough to know. When you ask, maybe switch it from a social construct just to ancestry. I don't know where I came from. I would love to know exactly what that means. And certainly as somebody who works with ancestry testing, there are people who call in all the time with the All of Us research program to say, my grandmother told me that we are from Turkey, and then you showed me that I'm from somewhere else. So the stories that we told ourselves over generations may not even be true because different borders and regions change. So what are we talking about here? Really want to question and figure out why we're asking those questions when it comes to ancestry and why we really think that we need it when it comes to providing care. Again, as Sally said, when it talks about talking about other things, if we're looking at measuring who's missing from populations, when it comes to talking about how things are taking place from a social construct, that might be a more appropriate space for that. But I know that's something that we're all willing to tackle. Sally, there have been quite a few questions in the chat when it comes to residual risk and expanded carrier screening. Didn't know if you wanted to touch on that.
Yeah, I can touch on that briefly. So I know this is something that for anyone who's ordering carrier screening, probably makes us panic a little bit to feel like how are we going to calculate these numbers? And I think again, race isn't a dirty word. It's okay to ask a person what their race or ethnicity is, and to use the detection rate information provided by the carrier screening laboratory to give a patient an estimate. But it's really important that we make clear to the patient, it's an estimate. There's no such thing as super precise residual risk calculation. We have to sort of get away from wanting to be very, very precise with that, because everyone is admixed to some extent. And so at the end of the day, what we need to be expressing to patients, especially if we're ordering sequencing-based testing, is that their residual risk is low. If, for example, one partner is a carrier and the other one is not, or if, of course, both are negative. That their risks are low, and giving an estimate is fair. And for example, for cases where there are certain conditions, like let's say SMA, for example, where there's a slightly higher risk for silent carrier status, important to bring that up and talk about, ways that they can manage that during pregnancy. But I think, again, we have to get away from trying to think that we can calculate a very specific fraction, and that is the end all be all of numbers. That's not reality anymore. So it's okay to ask the information, to give patients an estimate, but I think the bigger point at the end of the day, the patient's not going to remember a very specific fraction, and instead is wanting to know, how significant is my residual risk?
That's a great one. And there's been a couple of questions, because we are NSGC, asking, well, what is NSGC doing to help physicians, like Sally said, and to help strengthen these positions? Or what is NSGC doing to help us understand what to do with ancestry? And I think that's great to then go to different SIGs that you're part of, because depending on where you're working, there are already toolkits and things in place by those groups. Especially, I know for cancer, there is an anti-racism SIG or committee that you can join, and certainly those groups, if you can put that in the chat, that'd be wonderful for us to know that there are resources that are already there. But again, I also want to say, you are NSGC too. So if you think that, hey, there's not enough there, join one of these things. And for all the students that are there, hi everyone, good research projects that you can do or look further into doing. I know a lot of you already have some posters out for that.
Yeah, I know there's one study right now, and I saw the red cap link in the chat. So thank you for sharing that, but definitely an area where there's a lot more work that needs to be done. And thank you to all the students who are taking on that work and starting to get it done. Again, we'll get through a lot of these amazing questions later today at our hallway chat. But one theme that has come up quite a few times seems to be, asking, should we stop asking about REA data from patients? And should we stop using this? And I think it's a good question. We've hopefully helped show you why it is something that you don't need to be asking necessarily. But I think at the same time in our clinical practice, it still comes up. So for me, in the patients that I'm seeing, the only time where it's really relevant for me would be if there's a VUS that is interesting and possibly related to our patient's phenotype and has, a known founder effect or has a higher allele frequency in a certain population. And so is our patient from that population group or ancestral group or not? It's usually pretty easy and straightforward to just ask them specifically about that if that is a question. So it's not necessarily something that you really need to have upfront or beforehand, but that would be one setting. The biggest factor that affects my practice, at least, and would love to hear from Carla and Sally, are when labs require a race or ethnicity or ancestry, and they use those terms very interchangeably and a mix of all of them. It is not consistent or correctly worded. I would say genetic counselors reach out to those labs and ask them to change their form, ask them to change the terms that they're using and be consistent so that we're having aligned data points and definitions. But it's really, challenging when you are forced to select one option for your patient in order to order testing through a portal or, whatever the case may be. And so that's, in that case, I will, ask the patient up front and at least select something that they are choosing or feel reflects them and fits their identity, but it is not ideal. And I would prefer that is not a requirement from labs, or that labs really, drastically change and edit and review their process and how they're collecting that data and whether they really need it or not.
Thank you so much for that tidbit. And thank you all for joining. The conversation is not over. As we move forward, we do have a hallway chat that's available later on where we can discuss this more. Getting used to these changes is something that makes sense. So give yourself some grace as we kind of grapple with what do we do now that we know better and don't need to necessarily ask for race or ancestry. We can have withdrawal, just like sugar withdrawal or anything else that you do that's new. It's okay to fumble with it a bit, as long as you know that we can be doing better when it comes to race-based medicine and making health disparities something that doesn't have to exist in the genetic counseling realm. Enjoy the rest of the conference, engage with everything, and we look forward to seeing you soon.
Thanks, everybody.